how can we increase the chances that people will get into remission and stay in remission, stably in remission. And I'll talk a little bit about, in that regard, the recovery process and what we're learning about that. So, we're used to seeing slides like this, unfortunately, vis-a-vis the opioid crisis, as we all know. All too familiar with the preventable opioid poisoning deaths and increasingly, stimulants and other adulterants in the mix that are producing poisoning. This is, of course, also in the context of increasing alcohol deaths, which have increased rapidly in the last 5 years, gone up 25% as well. When we look back over kind of what's been happening over the last 50 years in our approaches since the declaration under Nixon of the war on drugs, there's a lot has happened, obviously, in 50 years. We've seen the birth of two national institutes of health, one, the National Institute of Alcohol Abuse and Alcoholism in 1970, and 1974, the National Institute of Drug Abuse, which has really helped enlighten us as to, the etiology and epidemiology, typology, neurobiology of these disorders, and it's helped us understand a lot about their nature, their course, and what seems to affect them in terms of helping these disorders and people who suffer from them to heal and to stabilize and get into remission. Now, having said that, there is still a great deal to be learned about these disorders, and there's still a lot of stigma and discrimination around these issues. I just want to touch on this issue just briefly because it is pervasive. It's in the air. It's kind of the oxygen that we all breathe in this field in terms of stigma and discrimination, because it's ever present when we're talking about these disorders. Stigma, of course, is an attribute, behavior, or condition that is socially discrediting. Discrimination is the unfair treatment of people who have that particular attribute, problem, or condition. And just an example of discrimination, I put this together a few years ago, but just to highlight a point here in terms of structural discrimination that people with substance use disorders face. So I've made this kind of recapture idea here. Please see if you can correctly identify all of the pictures which feature addiction treatment facilities and which treat other health conditions. And it's a slightly rhetorical question, but the point here is, if you were to look, you could probably guess which are the facilities that are treating addiction and which are those that are treating other kinds of health problems, because you can see there is a qualitative difference in terms of the quality of the environment, the facilities that are available and present for things like cancer and heart disease, diabetes care, that are not present for addiction and mental health. And this is pervasive, it's observable, and it's just one example of this kind of discrimination against mental health and addiction in particular. And what does that communicate in terms of discrimination? Is that people with substance use disorder often get treated in second-rate, dilapidated buildings, which gives them the impression they have a second-class illness. So not only do they worry that they'll get poor quality care because of stigma, but they also get the message that they're not deserving of environments that people with other kinds of medical, kind of real diseases get treatment. The kind of idea is that it's good enough for addicts. That kind of structural discrimination, but there's a lot of stigma that goes on across the world. This is a study from the World Health Organization, which really highlighted just how stigmatized alcohol and drug disorders are. This was a study across 14 countries, 18 of the most stigmatized conditions, and this included being HIV positive, being a criminal, as well as having illicit drug addiction or alcohol addiction. And you can see here universally across all of these countries and conditions, illicit drug addiction was ranked number 1, and number 4 was alcohol addiction of these 18 of the most stigmatized conditions. When we think about stigma, a lot of it has to do with cause and controllability and attributions around the particular attribute, condition, or problem, but it's also to do with how we therefore frame it and conceptualize it, and that has to do with our language and terminology. This is a question I often pose to audiences, which is people with eating-related conditions are almost always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as substance abusers and not as having a substance use disorder? I have never heard anybody referred to people with eating-related problems as food abusers. I don't know about you, but we tend to, and have done, refer to people with alcohol and drug problems as substance abusers, alcohol abusers, as opposed to having a substance use disorder. Does it matter? Does our language really matter? And of course, in this, it brings up the question of political correctness. And is it just political correctness, or does it have any impact, the type of language that we use? Can we induce, for example, biases in people who hear us talk about these conditions and people who suffer from them? Does that have an influence and impact on their judgment? It turns out it does. And we did a couple of studies, and this has been replicated by other groups as well. This is the first study that we did in 2010, where we randomized a vignette describing someone in exactly that terminology as being a substance abuser or as having a substance use disorder. And the same person was described using one of those two terms, and they were randomized to experts in the field. These were doctoral level addiction and mental health experts. And what we found was that at random, when experts were exposed to the same scenario, but describing someone as a substance abuser versus having a substance use disorder, they were more likely to view that person as in need of punishment rather than in need of treatment. When we followed this up in general public sample, we found even bigger differences. You can see them here. These are very large magnitude differences dependent on whether the person was described as a substance abuser versus having a substance use disorder. And look at the magnitude here, the difference, even starker than in the clinical expert sample. But when you use that language, describing people as a drug abuser or substance abuser, it induces this implicit notion that they are less in need of treatment, more in need of punishment, more of a social threat, more to blame, and more able to regulate the impulse to use, and therefore engaging in willful misconduct. So the implications here, of course, is that even when we don't mean it, even when we don't mean anything by it, anything negative by it, people, it tends to evoke an implicit schema, cognitive schema in people's minds that leads to different judgments. So language does matter because it does seem to induce, even among dedicated experts in the field, it can have an impact. This paper a few years ago also, I don't think we need a study to help us understand why we shouldn't use dirty and clean language in our clinical and public health settings. People often talk about dirty urines coming back from the lab, even a Mass General Hospital. But it's the kind of language that we shouldn't be using in our clinical and public health settings, I think for obvious reasons. So just a little, touch on that and the importance of how we conceptualize these disorders and relatedly, the language that we use to describe these disorders and people who have them. It does seem to make a difference. And also to pay attention to our structural environments, also in terms of resource allocation, because implicitly it does convey other kinds of discriminatory messages potentially. Again, that people are not worthy of being treated in high quality environments in the same way that we would treat other kinds of disorders. And I can tell you that even at Massachusetts General Hospital, which is viewed as a top hospital, there is differences in the quality of the environment for cancer and heart disease and versus mental health and addiction. It's gotten better, but it was much, much worse 20 years ago when I started at Mass General. It's changed, but still noticeable, observable. It's different. You may experience that there also in Connecticut, but certainly it's visible and evident. And of course, there has been pushes legislatively to create parity in compensation, in reimbursement for services around mental health and addiction. And I think we need to focus also on these other areas. Now, just coming back to zooming out here across this 50-year horizon that I started with earlier, and what we've learned a lot, which has helped us understand, again, what the nature of these disorders are and what to do about them. It's led to a number of paradigm shifts in the last 50 years in terms of the causes of addiction, the etiology. We understand that addiction is multifactorial, that there is a strong genetic basis. And this has helped to reduce stigma and discrimination because we understand, like other complex illnesses, there is a strong genetic basis. Some of us are protected by virtue of our DNA. Some of us are much more vulnerable by virtue of our DNA right out of the gate. Now, it's not just about genes, but certainly that does predispose people to increased vulnerability to these disorders. In terms of controllability, we've understood much more clearly about the impact in the neurocircuitry in the brain, of course, with chronic exposure to substances, how it changes the brain's neurocircuitry, which leads to impairment in the ability to regulate the impulse to use the substance despite harmful consequences. This is what we call and have called addiction for hundreds of years, but now we understand much more clearly the nature of it in the human brain. We've understood, of course, also about risk factors in the population in terms of onset and offset, as well as the pathways into substance use disorder, the clinical course, and the multiple treatments that have been developed and tested over the last 50 years to address these problems. And as I mentioned, there's been a number of paradigm shifts in terms of our understanding of the causes, the impact in the brain, what we understand now as neuroplasticity, that is to say, the neural adaptations that go on in the brain. Important thing that the brain can recover with abstinence, as you can see here, when you remove the poison out of the human organism, Mother Nature can do her work to repair the brain, the central nervous system, and there are certain environmental conditions, which I'll talk about today, which can accelerate that healing. We've also seen these stages of change, which has helped us to understand, this come up in the 1980s, of course, which has helped us to understand how people change addictive behavior, the kind of the stages that they go through from pre-contemplation to contemplation, preparation, action, and maintenance. Why is this important? Because it's helped us to map on, develop and map on different kinds of interventions that can help people, number one, stay alive, and number two, help resolve ambivalence about change. And I'm talking about, of course, harm reduction strategies, as well as things like motivational interviewing, which is designed to resolve ambivalence in these early stages of change, the pre-contemplative and contemplative stages of change, which help people resolve ambivalence and move towards more healthy behaviors, as well as other kinds of interventions like CBT and mutual help facilitation, which can help people stabilize, build coping skills, and then find support that can sustain recovery over time. Very importantly, of course, in light of the current opioid crisis, has been the emphasis on so-called harm reduction strategies. This has been life-saving. We've had the development of buprenorphine naloxone, which has been literally a life-saving medication, which has been helpful for preventing overdose deaths. That has been revolutionary in its ability to be able to do that. Prior to that, of course, we've had methadone as well as other strategies as shown here, which can help, number one, people stay alive, number two, help them stabilize with a longer-acting opioid agonist that can help reduce craving as well as prevent overdose. As I mentioned, psychosocial interventions have been very important in our development over the last 50 years in addressing these endemic problems, including the development, as I mentioned, of motivational interviewing, which was really the first approach designed to meet people where they're at psychosocially and help them resolve the ambivalence that probably that middle 60% of patients coming into outpatient services have. Of course, it's easy when people are very motivated. We don't need to resolve any ambivalence. But for roughly that 50 to 60% in the middle, oftentimes they're grappling with change. And this has been an important development in terms of sitting with people and helping them resolve ambivalence. We've seen the development of cognitive behavioral relapse prevention. This is very important. This has been easily adoptable around the world, that is based on cognitive behavioral types of interventions that clinicians can learn quickly and implement to good effect. And this has been very important. Contingency management, of course, one of the most evidence-based treatments. The good news is the Opioid Response Network, which is a federally funded initiative that anybody any clinician around the country can access and get consultation and training for opioid and stimulants use disorder treatment. You can go to opioidresponsenetwork.org and get free training in contingency management or CBT, courtesy of federal funding. And that's still going on. So please let people know about that, opioidresponsenetwork.org, and get training in any of these strategies to help opioid and stimulant use disorders as well as other disorders. We've also seen the development of so-called third-wave psychotherapies like mindfulness meditation, dialectical behavior therapy, mindfulness-based relapse prevention. Again, these have been important developments. Not that they produce better outcomes, but they help attract and engage more people, different types of people, into treatment, because not everybody wants a standard cookie-cutter approach. They're interested and engaged by different kinds of effective interventions. And this acceptance and commitment therapy, the mindfulness, again, it attracts more people in through the door and can help them find something that can be helpful to them. I mentioned this already in terms of medications. We have several FDA-approved medications for alcohol use disorder as well as for opioid use disorder, which are underutilized and can be very helpful, particularly, as I mentioned, with preventing overdose in the case of buprenorphine naloxone, as well as methadone for more severe opioid use disorder patients. Digital health, again, this has been another important development that enables people both on the front end to have a low threshold access to services that they might not be able to access via telemedicine, kind of teletherapy approaches from anywhere in the state. And this has helped people to access those services, of course, and a lot of the services now are done remotely. A lot of our services are conducted remotely with our patients in psychiatry and addiction medicine, addiction psychiatry here at Mass General. And this is good news. A lot of people, some people still want in person, but this remote access has been revolutionary. Of course, has really been thrust forward courtesy of COVID, where it came out of the COVID. One of the silver linings, arguably, of COVID was that we realized that we could do this and do more of this to good effect, certainly in terms of its reach. And we presume all those studies are being conducted in terms of its relative efficacy. In other words, is there a loss in therapeutic value by remote sessions compared to in person? And that's something that is being evaluated. But an important development on the front end in terms of access, but also in terms of recovery support on the other side. So when people come out of a residential or outpatient treatment, to be able to maintain change over time, people can use these mobile apps and other kinds of mobile technology that can help support change over time. I think another thing that's happened in the last 50 years, and the things that we've learned from all the studies that have come out of the NIH, is the realization that on the severe end of the spectrum, what we normally talk about as addiction or severe substance use disorder, these disorders tend to have a chronic course. And this is where a discussion has gone around treating addiction like a chronic illness, the way we would treat hypertension or diabetes or other kinds of chronic illnesses, where you would need to just provide acute services at particular discrete times, but also follow people over time to monitor them and intermittently manage the symptoms so that you can help them get back on track towards better health and remission. And we've understood now that the time frame, the timeline for people with these disorders in terms of their clinical course of the addiction disorder tends to be a long one, as highlighted here. You can see in the middle, it takes about 8 years. These are adults, clinical cases with adults who have addiction, so severe substance use disorder. It takes about 8 years after people, on average, start to seek help for their substance use disorder. So this is a mix: opioid, alcohol, stimulant, cannabis use disorders on the severe end. So these are addicted cases. But you can see it takes about 8 years after people start to seek help, and about 4 to 5 treatment episodes on average, or mutual help engagement episodes, before people achieve that first year of full sustained remission, that first year of recovery. So that's quite a long time. And people are moving towards recovery during that time, getting longer and longer periods of early remission until they get that one full year of sustained remission. But what's also noteworthy here from a disease management perspective is on the right-hand side, what you see is that it can take another 5 years after people achieve that first year of sustained remission before the risk of meeting criteria for a substance use disorder in the following year drops below 15%. Why is 15% significant? Because that is the annual rate in the general population of meeting criteria for one of these disorders in any given year. So to be no more likely than anybody else in the general population of meeting criteria for one of these disorders in the following year, if you've already had it, takes 5 years of sustained remission on average. So when we think about our services, the services that we provide and have developed, we've actually developed most of our services over 12-week periods. Most of our efforts in the last 50 years has been in developing these brief 12-week interventions, whether it's pharmacological or psychosocial, and then we remove the intervention and follow people up for a year. But what we are seeing here is a need for something like 5 years of continuous disease management or recovery management to help people sustain that change over time. Now, the question when we look at this long time frame, the obvious question perhaps that comes to mind is, can we speed it up? Are there things that we can do to accelerate the time to initial remission and to stable remission? Or do we just have to wait around for people to go through that 8 years on average and another 5 years? Or are there things we can do? I often use this burning building metaphor to illustrate this point. I think, as I mentioned, I think what we've done well in the last 50 years is recognize the crisis. The building is on fire, and there's something that we need to do about it. And we need to put the fire out, first of all. And that's what we focused on necessarily. That's been very important. How do we put the fire out first of this crisis? How do we stabilize people, detoxify, help them stabilize, and provide short-term intervention that can help people stabilize? But where we tended to drop the ball is after the fire is out, is to prevent it from restarting. How do we provide the building materials and the scaffolding that people need to be able to rebuild their lives after that fire is out, to prevent the fire from restarting? And I think also, very importantly, is the building permit, is that oftentimes people have prior felony convictions which prevent them getting access to a building permit. They can't get a job, they can't get back into school, they can't get a loan because of prior felony convictions. Sometimes it's just out of pure possession of an illicit substance. And this is something very serious because it can take the optimism and hope and motivation out of the wind in the sails of somebody who's ready to go, ready to move forwards in their recovery. But because they cannot get access to that building permit, they cannot start, and they can lose hope quickly and feel hopeless. And so legislatively, this is something very important that we have to work on, in addition to providing access to to the scaffolding and building materials that people need. We can think of these building permits and scaffolding and building materials as recovery capital. This is kind of a new buzzword, if you will, a new concept that's really describing a variety of recovery resources that people can gain access to and utilize to build momentum towards change, adaptive change and recovery. And you can see here, it cuts across multiple levels: individual, social, financial, and cultural. And all of these can help offset these kinds of resources can help offset the vulnerabilities that are evident in these early weeks and months and years for some people of recovery. Most notably, the central nervous system, of course, is in many cases of addiction dramatically affected as a result of chronic exposure to substances over many years, sometimes decades. And when the drug is removed, there is these two phenomena that are observable in the central nervous system. One is increased sensitivity to stress. The other one is a decreased capacity to experience normal levels of reward. And this is, of course, is because the central nervous system has become accustomed to these abnormally high levels of reward and reinforcement. And this, in the absence of the drug, where the brain has adapted to the presence of the drug, when it's removed, there is a withdrawal and a post-acute withdrawal set of symptoms that occur, which is manifested through these different pathways. So it's very difficult for people early on in the early months to experience normal levels of reward, just because those receptors, dopamine receptors, have been downregulated because of exposure to these abnormally high levels of reward and reinforcement. And as I mentioned, we call these post-acute withdrawal phenomena, but they're really manifested in those two different pathways of the stress sensitivity as well as the downregulated reward pathway. It makes it very difficult for people to adjust and adapt. Things just don't seem as good as they once were pre-morbidly before they succumb to the substance use disorder. The other thing, of course, is that the rewards of substances are immediate, potent, and predictable, and the rewards of recovery are delayed, diffuse, and variable. So there's a natural bias towards continued use, just because there's nothing quite like a drug that will produce immediate, potent, predictable effects in our life, right? There's nothing. Our social reinforcers are good. They help us feel better, but they tend to be a little bit more variable and more delayed and more diffuse. And so this is a bias that tends to persist and takes a while for people to adjust, of course, to that. There are different models that we could use to describe and understand this phenomena, but I like this one. This is we have adapted from Hans Seeley's initial work on the general adaptation syndrome, where he was studying animals in response to stress in animals. But I think it fits the addiction paradigm very well also. In Hans Seeley's work in the 1950s, he was looking at how organisms respond to stress, and he found that when you stress an animal, there's an initial alarm reaction within the central nervous system of the animal, and then it starts to resist, produces resistance. The endocrine system is activated. It starts to resist, but it becomes exhausted. You can see here on the right-hand side, it becomes exhausted after a while, and then can get sick and die. I think this fits very well with the addiction pathway in terms of typically what happens is there is an alarm that usually an alarm incident or accident or injury or overdose that leads people to enact a change. They say, this is it, I'm going to make a change, I don't want to go through this again. And they resist until, again, without the proper support, they will become exhausted and they can sicken and die. And so the question is how can we prevent that exhaustion from happening? And this is where access to these building materials, the scaffolding, the building permits are absolutely vital that can help support remission. And this just illustrates this point that it's remission and recovery capital are intertwined and reciprocal. That when people initially stabilize, they begin to naturally accrue better mental health, better cognitive functioning, greater psychosocial stability. But we can also influence the chances of ongoing remission by providing access to the building permit, the building materials, the scaffolding, which can help reduce that allostatic load, that stress load, and increase the chances of remission. So, what about the active ingredients of recovery and sustained remission? What have we learned there? What are the factors which seem to be associated with accelerating the time to initial and stable remission and remission more quickly? Well, we know, as I mentioned earlier, that addiction itself, of course, is multifactorial. You can see the multiple interacting factors from biology and the interaction with the environment over time that can increase risk, and then exposure to the drug changes the brain, and that can lead to addiction. Um, Similarly, for recovery, again, it's a complex process, a complex, multidimensional, interactive, dynamic process. But instead of the drug, it's recovery capital. When we instill recovery capital or infuse recovery capital, make people have access to that recovery capital, that again can change the brain and lead to recovery. Um, and You can think of recovery in terms of its relationship to remission as kind of weatherproofing. We can help people achieve remission, as depicted here on the right-hand side. You can take some planks of wood. If you remove the disease from the wood, you've got some nice planks of wood. They don't have any disease. They're durable. But if you coat the wood, if you provide a protective sealant, then you're more likely that wood is now protected against future disease. And you can think of recovery as building resilience against the loss of remission status. So how do organisms recover? Well, one metaphor, again, is to think about it from an ecological standpoint. When we think about, after all, there's only so much we can do at any given point in our treatment system. We can detoxify, we can manage withdrawal, we can provide medications, but then they have to go out the door and they have to go back into their environment. And it's really about what kinds of environments people find themselves in or can access that is able to provide healing. Think about a plant that is diseased or sickened. When we provide the right conditions, the right soil, the right moisture, the right temperature, the right light, that plant which was once sick and not doing well, where the leaves are falling off, now actually starts to recover, provided that we provide those right conditions. There's so much you can do to a plant at any given point in time, but you provide the right environment, and the plant can photosynthesize. I think of recovery as a kind of a psychosynthesis in the same way, in that if we can provide the right kinds of conditions, again, that scaffolding, building materials, permit, and provide the right kind of context and conditions over time, we can help accelerate healing. And these are really broad stroke, the kinds of things that need to be provided. You can think of the social environment in our clinical and recovery support service settings as the soil through which all the other nutrients and aspects of recovery are absorbed and exchanged. Activities, that's both physical activity, just building physical resilience. Many people have physical health problems or are underweight because of malnutrition and other inactivity. So building physical resilience, but also education, jobs, other kinds of activities which can support mental health and meaning and purpose. Nutrition, just eating 3 meals a day, of course, is very important for many people early in recovery, but then in introducing as well antioxidants and other kinds of balanced nutrition which can augment and supplement brain health and support brain health. And emotion regulation, very important aspect, of course, of recovery, as I alluded to, with those two vulnerability factors, the stress, the anxiety factor, and the lowered ability to experience normal levels of reward can lead to difficulties in emotion regulation. Arguably, achievement of these other three, above and below and to the right, can help emotion regulation, but there are things that we can do also directly to help people regulate emotion through things like cognitive and behavioral interventions and mindfulness interventions, for example. It turns out that we can affect the brain and these downregulated pathways in the brain, both from the inside out as well as the outside in. Now, we're familiar now, as I mentioned earlier, with these brain neural circuits shown here, of reward, memory, motivation, impulse control, and judgment. These are the neurocircuits which are associated, implicated with this impaired ability to regulate the impulse to use despite harmful consequences. This is what we call addiction. And this is, of course, why it is a psychiatric illness, because of the involuntary nature of it. It doesn't start off that way, but it becomes that way, and that's how it becomes a disorder. Now, it turns out that we can actually help to heal these brain neurocircuits, both through providing access to medications from the inside out, but also from the outside in. Now, think about, here's a kind of a paradox. What are the four main reasons? I often ask this question to audiences. What are the four main reasons why people use a substance? It's usually to feel good, to feel better, to do better, performance enhancement, or because other people are doing it. So there's social pressure. What do you think the four main reasons why people stop? To feel good, to feel better, to do that because other people are not doing it. So it's a paradox. So it's what started out to help me feel good, to feel better, to do better. The train leaves the station, it's feeling good, it's working, but at some point down that road, as the brain starts to change and become accustomed, it starts to do the opposite. Now I want to get off the train. Why? Because I need to get off this train because I need to feel good and feel better and do better. That this substance now is absolutely causing those problems that I used it to once help me heal. The important thing here also is the social factors here at the bottom. People can get into substances, of course, through these social networks, and they get out of them as well through these social networks. And our social relationships actually are important, not just for recovery and mental health, as we know instinctively and intuitively and experientially, but also it helps with longevity. And this is a very powerful study that was done by Julianne Holt-Lunstad showing how social isolation and loneliness leads to premature mortality, independent of other risk factors, leads to premature mortality on par with cigarette smoking. So that magnitude of effect, not just mental health, but actual physical health and longevity, potent social influences on our well-being. I think that's why the Surgeon General was really making the case a few years ago on the importance of social isolation as a public health risk factor for disease and premature mortality. Now, the reason, of course, is our social interactions, whether you're suffering or have suffered from a substance use disorder or not, affect these neuroendocrinological systems. In terms of increased sensitivity to stress in the recovery sense, from an addiction perspective, we know that social buffering can help these neuroendocrinological systems to cope better with stress. So again, when we seek out social support, it releases a whole cascade of in the neuroendocrine system in terms of oxytocin, reducing cortisol, reducing negative hormones, stress hormones, and that can help us to feel better and mitigate stress. When it comes to that other vulnerability, the downregulated reward pathway, once again, these social interactions have been shown to upregulate these downregulated pathways in the dopamine system. Look at the magnitude here of the relationship between social support and upregulation of these dopamine receptors, as well as social status. Very similar magnitude in terms of producing increases in the striatum of these downregulated receptor systems that help us to feel better. This is very important, of course, in recovery, and particularly early recovery, in other words, to expose people to supportive role models, as well as the social status variable. And you can think of social status as autonomy and access to resources. So the greater autonomy and ability to regulate, self-regulate, as well as have access to resources, which of course we need to provide to help people build that momentum, as I mentioned, the optimism and hope for recovery, that is to say the building permit, the building materials, the scaffolding. They can increase their personal social status by increasing autonomy, independence, as well as these resources. Now, this is why I think there has been this growth, the reasons that I've been talking about here, in terms of those factors, those active ingredients, particularly the social networks that provide the exchange of those nutrients that can help people recover, upregulate these downregulated dopamine receptors, as well as mitigate stress, the overactivated stress pathways in the brain, central nervous system. There's been this tremendous growth across the country and around the world in the last 100 years, but in particular in the last 30 years, in terms of the variety of because there's been increased recognition of the need for these kinds of structural supports for people who are we're doing a good job, as I mentioned, of putting out the fire and stabilizing, but how then do we keep the fire from restarting and help them achieve and sustain remission and achieve stable remission more quickly? You can see here on the right-hand side the variety of different kinds of recovery support services. These take the flavors of mutual help organizations, 12-Step, and others like LifeRing, Smart Recovery, Women for Sobriety, myriad online ones now as well. Again, these are social networks of support with people with lived experience who've been there, done it, and come out the other side, are living lives in recovery, in remission, that can help provide role models as well as support for people who are looking to achieve remission and get out of the fire of addiction. There's also been more professionalized versions of mutual aid by way of recovery coaching and peer recovery support services. These have been implemented in our clinical settings, in our emergency departments, and many other settings where people with addiction find themselves, again, to provide that peer support, lived experience, role model, and flexible support that can help people navigate early recovery. Recovery residences are, again, very important in terms of providing access to housing, stable housing where they're not at lower risk for relapse, as well as clinical models of recovery management. Recovery community centers, New Kids on the Block. We'll talk about that. We've done work across Connecticut, actually, as well as the New England states, looking at New York State, looking at recovery community centers, what they provide and how they help. And then recovery supports in educational settings, collegiate recovery, recovery high schools, as well as employment settings, actually, recovery-ready employment settings, which have been helpful to support people in organizations who succumb to, who have substance use disorders. Now, the advantage of these community-based services, in addition to our clinical services, is that these services they're available, they're accessible, they're flexible, they're enduring, and they're low to no cost. This is a good match, in other words, for that undulating course in those early years of instability and susceptibility after initial stabilization. So I think this is why they have grown. What we have found when you look at the entire body of scientific literature, which is growing across these recovery support services as augmenting our clinical services, is that they have tended to increase sustained and stable remission rates. They reduce overdose and infectious disease transmission. They reduce overnight stays in the hospital and emergency department visits. So they reduce costs. They reduce arrests and legal costs, and they increase employment rates. In fact, when we did this modeling analysis, this was published in Science Advances 2 or 3 years ago, led by Aaron Stringfellow. What we found here, this was looking at opioid use disorder and overdose deaths in the United States. We're looking at the next 10 years, so trying to predict the best things to do over the next 10 years in terms of preventing overdose and preventing opioid use disorder. What we found was that in addition to Narcan, so naloxone, and preventing overdose deaths in the most immediate sense, as well as providing buprenorphine, the best way to prevent opioid use disorder in the next 10 years was keeping people in remission. And the best way to do that was providing greater access to recovery support services. So that was an important finding and data point because we need to put the fire out, but then what do we do next? What do we do after that? After the fire, is that how do we get people into that next phase, build momentum, build optimism, build traction, so that people can build a life in remission and sustain it. Mutual help organizations, in terms of our data, the data that's been accumulated, as I alluded to just now, in terms of what we know about the effectiveness of these kinds of services, are quite compelling. We have the strongest data for mutual help organizations because they've been around the longest and they're the most ubiquitous form of recovery support, particularly AA, 12-step, and particularly Alcoholics Anonymous, which has been around the longest and is the most ubiquitous recovery support service in the world. We published this Cochrane review in the Cochrane Library 4 or 5 years ago now. But what was interesting about this review was that we took all the randomized controlled trials of clinical linkages to AA. These are people with severe alcohol use disorder, alcohol addiction cases. And there were 27 trials in this review, systematic review. What we wanted to do here was hold 12-step treatment and AA to the same scientific standard as we would any other kind of intervention. And what was quite compelling and surprising here was that the relative advantage of linking patients with alcohol addiction to AA versus providing some kind of other treatment that did not link patients to AA produced equal benefit. So they benefited equally across all the outcomes except continuous remission and abstinence, where linkages to AA did much better. You can see here in the yellow bars, this is in the top layer of evidence, that patients that were linked to AA had 20 to 60% higher rates of continuous remission over up to 3 years compared to those who were linked to other kinds of treatments like cognitive behavioral therapy or motivational enhancement therapy. So producing as good or better outcomes when it comes to remission status over time. And not only that, but it produced, when we extrapolated to the US population, it would produce $10 to $15 billion a year in healthcare cost savings alone. So this is not even including arrest reductions and employment increases, but $10 to $15 billion alone. We've also found discovered how groups like AA confer benefits. Turns out that when you look at the body of literature which has examined the mechanisms through which groups like AA confer recovery benefits, in other words, how do they help people sustain remission over time, it's through these mechanisms. It changes their social network away from heavy drinking, drug-using networks into more abstaining, recovery-oriented networks. And then look what happens thereafter is that it starts to boost cognitive behavioral relapse prevention coping skills. It enhances and maintains motivation. It helps to boost self-efficacy and self-esteem. It reduces craving and impulsivity and increases spirituality and meaning and purpose, which people can deploy to help them make sense out of suffering and stress. You know, I refer to AA and groups like it as the closest thing public health has to a free lunch for these reasons. We don't have anything like a free lunch the way that we do with these mutual help groups. But of course, not everybody wants to go to AA. And this is why I think there's been a growth in the other kinds of services, including mutual help, because people need different flavors. I often use this different metaphor of a gym analogy, a fitness center analogy. The question I ask is, do fitness centers work to keep people fit? And the answer, of course, is yes. So if you can go to a fitness center, you're going to find something that you like to work out with or do a class or something there. So fitness centers know this, of course. So when you walk into a fitness center, do you just see 40 elliptical machines and that's it? Now, it's true, it's a fact that elliptical machines, if you work out in the elliptical machine, you get physically fitter. If you do that 3 to 5 times a week for 30 to 45 minutes, you will become physically fitter. That's a proven scientific fact. But what happens if you don't want to work out on an elliptical machine? Now, fitness centers know this, of course. That's why they don't just have 40 elliptical machines. They've got 40 different classes. They've got gyms, pools, everything you can think of right there. Why? Because they want to attract more people through the door into some kind of physical fitness activity. The way that we have gone now, I think, and starting to move more clearly, is in the same way in our recovery fitness, if you will, is instead of, now we know the 12-step works. Yes, if you work out as it were, work out in your 12-step groups, yes, you will get fit for recovery. But if you don't want to work out there, what other flavors do we have? And this is where there's been this increasing repertoire of other kinds of mutual help groups and other kinds of services so that people can find something that's their speed, that's their flavor, that can attract and engage more people. Remember I said about the mindfulness relapse prevention. They're not better. They don't do better, have better outcomes, but they're likely to attract and engage more people through the door. So it's less a question about relative efficacy than it is about attraction and engaging more people. Don't forget, we only attract about 10 to 20% of people every year who have substance use disorder into some kind of service. So we need to do a better job of increasing the repertoire of options that people can get involved in. And the good news is that when people select, when they self-select some kind of service that's suitable, that's their flavor, their speed, they tend to have as good outcomes as those in more traditional 12-step groups, for example. And as I mentioned, we're understanding more about the mechanisms. What about recovery residences? Same story here. Recovery residences, it's a randomized controlled trial, randomizing patients with severe opioid, alcohol, stimulant disorders to go home and receive outpatient treatment as usual, or live in a recovery residence. These 2 outcomes, you can see the magnitude of the difference here. These are large magnitude differences in terms of lowered substance use, higher employment rate, lower crime and recidivism. And all that mounts up to $30,000 per year in savings to society per patient. So a whopping savings there, not just in terms of improving clinical outcomes, but reducing economic burden as well. Recovery community centers. CCAR in Connecticut has been a leader in this regard. In fact, 20 years ago, I think I went down to see Phil Valentine in Hartford and visited the Recovery Community Center down there. I was really inspired, which led to me doing more research in this area, really looking at the clinical and public health utility of these recovery community centers. These are bricks and mortar, as many of you may know, bricks and mortar buildings, and typically in the hearts of communities, which provide access to these building materials and scaffolding I was talking about, the kinds of services that these can provide for recovery. And this is the array of the kinds of things that these bricks and mortar buildings can provide. The people that are populated by people in recovery who have that lived experience, and they can provide and do provide all these kinds of services that people can go and access or get linked to that can help them, again, find these building materials and the scaffolding. What we're also finding is that, consistent with the theory underlying these centers, they provide something quite unique that's not provided by mutual help or recovery residences. That is to say, it helps build this recovery capital, and that in turn boosts these other factors, which helps to reduce relapse and recidivism. This is a study we've just finished in Massachusetts showing the benefit here relative to, these are people starting a new recovery attempt, going to recovery community centers versus some other pathway. And you can see here in red the benefits over time: higher remission rates, lower substance use consequences, higher abstinence rates, fewer psychiatric problems, higher self-esteem and positive social identity, higher happiness, double the employment rates, higher recovery capital, and greater gratitude, which is a marker of resilience. So the good news is that these these kinds of services are providing access, the kind of building materials that people need that can help build optimism and hope and gain traction. What's also noteworthy is that when we look at the recovering population, and these data I'm showing you right now, these curves are from our national recovery study, where we sampled a representative sample of the US adult population, about 50,000 people. And we estimated that there were about 10% of US adults in recovery from a drug or alcohol problem. And in that sample, what we found was that it took, on average, for people in recovery from a substance use disorder, it took them about 15 years to achieve the same level of quality of life on average as the general population. So that's a very long time to achieve the same quality of life as the general population. But for people who are accessing these recovery community centers, it took them only about 5 years to achieve that same level of quality of life. And again, can we accelerate that time to stable remission? It seems that providing access to these kinds of recovery support services, those building materials, the scaffolding, the building permits, that they can begin to access that kind of recovery capital that has the potential to stabilize them more quickly and build resilience. Now, where we're at now, I think, is, and some of you may have long been in this world of connecting the dots here between our more expensive clinical services and these free, ubiquitous, indigenous recovery support services, which are growing in the multitude of, in quantity, but also in the types, is that we need to do a better job of connecting the dots between these clinical services and these services in the community, which can help support individuals, again, over time, because we're talking about that initial 5 years of potential risk and vulnerability that we need to attend to that can help support people, build recovery capital, and build remission. The last thing I'll mention in the last 10 minutes before we open up for questions is recovery milestones. Now, this is important because we need to think about who needs what, when, for what duration, at what intensity, right? Who needs what kind of service for what duration, at what intensity. And we have these different milestones here on the left, which are associated with the particular aspects of vulnerability and thresholds. So in terms of who needs what, when, for what duration, what intensity, again, this is the recovery curves. You can see here these different dimensions of quality of life, happiness, recovery capital, self-esteem, and psychological distress. The nice thing here is across these 40 years of recovery, across the bottom of this graph here, people with just a few weeks up to 40 years of recovery, you can see the nice incline in these indices of quality of life and functioning, and the decrease in distress. See the psychological distress coming down, sweeping down with more time in recovery. That's good news. That's something we need to communicate to people better, that life gets better. And this is, by the way, independent of age. So apparently, as we get older, we get a little bit better off. We all get a little bit happier. Apparently, we've got that to look forward to, I guess. But even independent of age, these things are still apparent in the recovering population. But what's interesting is that the accrual here, that the benefits do not occur at the same rate for everybody. For example, if you look at these two graphs in quality of life and recovery capital, you can see that the opioid and the stimulant group, the opioid group in green, stimulant group in yellow, had a harder time out of the gate in terms of improving their quality of life and access to recovery capital. Now, in part, that is because those groups are more marginalized and stigmatized than other groups. They're almost one full standard deviation lower than people with alcohol, more acceptable, if you will. Now, those people are not doing particularly well either, but relative to those individuals with cannabis and alcohol use disorder, the stimulant and the opioid groups start off at a much lower level. It takes them on average 2 to 3 years to catch up to the same level as the people with alcohol, primary alcohol, on average. primary alcohol and cannabis use disorders. So it means that those individuals with opioid and stimulant use disorders may need more access, greater access to recovery capital and more resources. And in fact, what we find in our recovery community center research is that they are overrepresented in those settings because they need those resources. There's lots of people with alcohol use disorder there, but when you consider the much lower prevalence of opioid and stimulants use disorders relative to alcohol, they're overrepresented in these recovery community centers through CCAR and other centers around the country. Also, racial ethnic disparities, in particular, Alaska Natives and Native Americans continue to have a very difficult time in recovery. Again, looking at these graphs of quality of life, psychological distress, and happiness, they tend to be much more marginalized, have difficulty, again, trying to understand who needs what, when, for what duration, at what intensity. Sexual minorities, big magnitude differences here right across 40 years. So people who are have sexual minority status, gay, lesbian, bisexual, in particular, you can see here big disparities in terms of self-esteem, recovery capital, distress, and so on. Racial, ethnic, and spirituality. This was very interesting to me when we looked at this, just how different spirituality and religion is among different racial ethnic groups. The question we asked in this study from our national recovery study was, to what degree do you consider yourself to be spiritual and religious, and to what degree did your spirituality or religion help you achieve your recovery or help you in resolving your problem with alcohol and drugs? And look at the magnitude of the difference here. Look at the top right-hand side. For Black, people who are identified as Black, almost 50% said that spirituality made all the difference in their recovery compared to all these other groups, including white folks here down the bottom. So almost 3 times as many people in the Black community said that spirituality and religion made all the difference. Not just helped a lot, made all the difference in their recovery. Think about that. How often do we actually attend to that in our services in terms of talking about raising the issue of spirituality and religion? But it may actually be a very important matching variable along those lines. I think that's very important. Another thing that is apparent here in terms of who needs what is that there is an inflection point. Remember earlier I talked about that timeline where that 5-year, there's something about that 5-year marker where after 5 years, you're at no greater risk than anybody else in the general population of meeting criteria. If you've already had the disorder, you're no greater risk than anybody else in the general population. We see that reflected here in our national recovery data. This is where the slope of the curve changes, both in terms of psychological stress and all these important aspects of functioning. What's also very interesting is when you look at, zoom in under the microscope here, looking at the first couple of years of recovery, and you look at these indices of functioning, look what happens in the second half of the first year. People are doing well, they're stabilizing, they're convalescing. And then the second half of the first year, people are dropping. Their quality of life, their self-esteem is dropping in the second half of that first year. What do you think is happening there? People are still in recovery here, but they're dropping in these indices. Now, what might be happening is that, again, if we think about this burning building, is that after the first 6 months, the fire is out, and then the second 6 months, the smoke is clearing out of the building, and people are starting to appraise the damage. And people are starting to look around and say, oh, look what I've got to clear up. And they look forwards in their life and they say, look what I've got to make up. So those two thoughts, look what I've got to clear up, look what I've got to make up, can be very daunting thoughts and propositions for people early in that recovery process after that initial 6 months. Now, it may be that that is part of what is going on. I can tell you just clinically, but that phenomenologically, that is often the case. There's a period of convalescence. For some people, it's a bit of a pink cloud, and things go well for a while. But then when the dawning of reality that I call here on this curve, the dawning of reality occurs, the smoke clears out of the building, there is deeper realization of what people have to do. Now, if people say, look what I've got to clear up and look what I've got to make up, we can support them and say, yes, there may be a lot to clear up. There may be time to make up, things to make up. But if we can provide access to those scaffolding, to those building materials, then people can start to climb up this slope again and build that resilience and recovery resilience towards greater conservation and growth. To end, again, I talked about this a little bit about um, the fact that we only reach about 10 to 20% of people with substance use disorder. Now, those tend to be the more severe end of the spectrum, of course. People are more motivated, they're in pain, they're suffering more, they tend to reach out for help, or their family members do. But there's about 80 to 90% of people that still contribute to the burden of disease, economic burden out there who never set foot in a treatment facility. How do you reach those folks? Now, these digital services can be very helpful. And there's more research being done on kind of reaching people in their living room, on their computer, on their smartphone, so they can maybe do some screening at home, maybe begin to self-change at home, providing greater access to those kinds of things online that people can begin to utilize. That's very promising when we think about reaching this other huge segment, the majority of people with the mild and moderate end of the spectrum. But I think we should remember also that in a high-tech world, at its core, recovery remains low-tech. There is still this need for many people for this personal connection. I love this refrain. I use this a lot. Tracy Chapman's song Fast Car, many of you may know it, great song. But in that chorus, she says, and her arm felt nice wrapped around my shoulder, and I felt like I belonged, and I felt like I could be someone. And I think those two facets, belonging and becoming, are very important optimism assets of recovery and recovery support services. It's something, of course, that we try and instill clinically by instilling hope that people can make that time, can clear up the wreckage, can make up time and become who they're meant to be. But I think also in terms of our recovery support services, in that sense of belonging that people feel very isolated, very stigmatized, very discriminated against, that if we can help them to feel belonging, that can be very powerful healing ingredients, as well as giving them optimism for helping them become the person they were meant to be, unencumbered by addiction. So with that, I will stop there. I think we're at 10:15, and we can open it up for questions.
Yeah, so if anyone has any questions, feel free to either put it in the chat or just use the raise hand feature and we can go around and address them.
Hold on a second, just someone knocking on the door. Holly, sorry about that.
Not a problem. Does anyone have any questions? Someone's asking, there was a slide showing a bar graph of residential incarceration, other option. I jumped on late, but wanted to circle back and ask about the data there.
Residential, I think that was probably the Oxford House study, the residential, yeah.
I think that's one.
Yeah. So that was there was a randomized study where they randomized patients with opioid stimulant alcohol use disorder after intensive treatment to either go home and attend outpatient treatment as usual, or to live in a recovery residence. And what they found was that over a 2-year follow-up period, when they followed these folks over 2 years, they found that those who were living in a recovery residence versus going home and receiving outpatient treatment as usual, the ones in the recovery residence had twice the remission rates, twice the employment rates, and 2/3 lower crime recidivism rates. And that had a cost savings to society of $30,000 per person over that 2-year period. So it produced better outcomes and lower costs to society. And that's just another kind of example of, I think, what can be achieved when we link from our more expensive clinical services to these ongoing, more enduring community-based services. We've seen this, as I mentioned, with mutual help in the studies on AA and reduced healthcare costs, because AA tends to do a good job of helping people sustain remission over time. Those individuals are not crashing their cars, ending up in the emergency room, staying overnight stays in the hospital. So it tends to reduce the burden on the healthcare system, as well as reducing, of course, legal costs associated with processing things like DUIs.
So was it more so the treatment approach? So you mentioned clinical. Is it just clinical? Is it also like peer support? What approach is the treatment consisting of? Just so I understand a little bit more. And maybe I have to look at the study itself, but just like your consensus, what cohesive approach is the best to sustain those type of results in potentially in our work?
Yeah, thank you. Yeah, great question. Yeah. Well, it's again, it's trying to connect the dots here. It's trying to create the linkage when individuals come into emergency departments, when they come into intensive clinical settings or outpatient settings. It's after you've stabilized them, or after you've provided 12 weeks of a manualized, intensive outpatient. What's next? Think about what's next. What do you do next? You just say goodbye, discharge them, or can we link them? Can we link them better to something else? Given what we know of this 5-year susceptibility, 5-year timeline of vulnerability, can we connect them with mutual help resources, with recovery residences, with recovery community centers, with employment-based recovery support services, with educational-based recovery support services? It's really thinking beyond our clinical purview, our narrow clinical view, which is often around stabilization and short-term brief treatment, to linking them to indigenous, ubiquitous, supportive resources in the communities in which they live and work.
Wonderful. Thank you so much for the feedback. I appreciate that.
Thanks for the question. Yeah.
There was a comment, just a comment. I really like the evidence to back up what many of us already know intuitively. No, the connection is the opposite and antidote to addiction.
Yeah, exactly. As I mentioned, in that model of kind of psychosynthesis model I presented, that I think the social factors are the soil. You can think of that as the soil through which all the other nutrients are exchanged and absorbed. That's where the exchange happens. We're always trained clinically to be empathic, to be warm, to be welcoming. There's a good reason for that, of course, is that we don't like that as human beings. We want to belong. We want to feel welcome. We want to feel that people care. As the old saying goes, people won't care how much they know until they know how much you care. Caring comes first, and that trust and rapport is critical for engagement. Peers with lived experience, of course, they naturally have that. They possess that. It helps to build that instant trust that people have or people need when they come in the door. So if they know you've been there, you've done it, you're a living role model of having gone through it and have successfully navigated a course in recovery, that's very inspiring and reassuring and helps to build that trust. And I agree, as we know from the neuroendocrinological research and the dopaminergic research, that those social factors, they don't just help us psychologically, but they help upregulate these downregulated receptor systems as well. So it's a biopsychosocial phenomenon.
And then I just had a question too, because in my other job, I'm a licensed social worker, so I see clients directly. And I know we talked about like how it takes 8 years after people try to seek help, and then 4 to 5 years, 4 to 5 treatment types before like they're in remission. And from my experience, a lot of my clients who have either gone beyond those 5 times of trying, or they're right there, it's really met with a lot of hopelessness from them, and then internalized failure. And I'm just wondering, I know we talked about the scaffolding, but is there more we can be doing on a clinical side when we're treating these patients one-on-one who are having just these kind of hopeless feelings?
Yeah, I would say, is to let them know that the majority of people will eventually get into remission and into stable remission. I mean, from our national surveys, we now know that from the National Survey of Drug Use and Health, 72% of people with a substance use disorder are living in remission. They get into remission. So 3/4 of people are getting remission. Yes, it can take a while, and for some people, it can take a long time. Like you said, Holly, again, 4 or 5 is the average. So that means, half are getting lower, getting into remission using fewer, some more. And it tends to be skewed positively. So you get a very small number of patients or individuals who need many more, but they're a minority. But what I say to people is don't give up hope. You never know. Recovery and remission can be right around the corner in your next attempt, and don't give up hope. And help them to look at what's helped in the past, what's not helped, and how can we supply what you need better, and what things have you learned yourself that you found to be helpful, and can we amplify that? Can we extend that? Can we make it easier for them to access the resources? So always try and instill hope that the most likely outcome here is recovery, but it can seem hopeless at times. That absolutely for sure, but we can use that sense of hopelessness. So look, this is you're feeling hopeless right now, but it's what can you learn from this experience, and how can you put it to good use?
Thank you. Yeah, it's like when they say that to me, I just want to shake it, and I'm like, you're so worth this. Like, you can do this.
That's wonderful. Yeah, because they need to hear that too, right? Absolutely. We want to make sure that they feel cared about, because they feel lousy about themselves. That's for sure. They feel horrible, a lot of self-hatred sometimes about the repeated failures and the people that they've let down. And they feel terrible about that. And that, of course, can lead to all kinds of, mental health challenges and problems. So anything we can do to reassure them and help them just take that next step forwards, dust themselves down, and provide access to the things that they need and can benefit from.
And then we have Tung said, Dr. Kelly, thank you for the information presentation. What I am about to ask may not tie to the materials you presented, but do you know any studies looking into drug checking and how it helps community, especially people who use drugs, and what impact the drug checking component has on treatment services, and then journey home? Also, emphasized that and said, what are your thoughts on harm reduction techniques?
Mhm. Yeah, great. All of those are good. There have been, I think, some qualitative studies done on drug checking. I think we featured some in our recovery bulletin. But all of these services, all of these things are their attempts to try and reduce harm, reduce poisoning deaths, increase the likelihood of engaging people in services that can, number one, prevent overdose deaths, number two, prevent infectious disease, number three, hopefully move people towards healthful behavior change that can help them feel better and do better in their lives. So all of these things, so-called harm reduction services and the expansion of those are critical for those reasons. And they're a part of a very vital part of the spectrum of services that are needed for helping individuals who suffer from these disorders. I don't know offhand, unfortunately, what some of those preliminary qualitative studies on drug checking produced. I know we've featured a couple of them in the recovery bulletin, but I can get them to you if you email me.
Okay, perfect. And then Beth and then Ebony, I see your hands up. So Beth, go ahead. Doctor, can you hear her?
I can't hear anything.
Yeah, Beth, we can't hear you.
About this one. I'm
Yep.
switching, okay, switching microphones. You guys were talking before about how somebody who's attempting to, recover and abstain from substances and things like that, how they might be feeling about themselves and how that might impact like that sense of hopelessness, like, impacting their continued attempts in that. But what I often see is it not just being about how they feel about themselves, but like an existential level, like stuff going on. It's like you're asking me to join in a world that's so fundamentally broken, like that I don't want to like necessarily be a part of in a normal typical way. Like you want me to get a job and pay rent and do all these things in a broken world that's never worked for me. And I'm broken, the world's broken, we can just leave it at that, like kind of feeling. So I was just wondering your thoughts on that. I don't feel like it's always just how they feel about themselves, but it's how the world looks to them that and feels to them that is a struggle.
Absolutely, Beth. Yeah, it's when people, what you're describing is really a paradigm of just severe hopelessness based on experience of closed doors, and being shut out and discriminated against. And that's why I think these, in particular, so even in our clinical settings, we can provide in our clinical public health settings, empathy, support, direction, referral, linkage. But where people, I think, can find that hope is through other people who've been there where that person has been, and through exposure to those peers in recovery. We're not selling anything. They're not selling anything. All they're doing is they're saying, look, I've been there where you're at, but I found a way that helps. Why don't you come in? We'll give you a cup of coffee. Let's have a talk. And you're welcome here anytime. We want to support you. That's what I love about these recovery support service settings, is because they're populated by peers, and increasingly with recovery coaching models in our formal services, that is greater permeability and porosity between our clinical and community. It's become more of a two-way street, and I think that's where it needs to be, where we can have more peers with lived experience in our clinical settings to provide those role models for people and help people in those instances you described where they're feeling really hopeless. And like you said, an existential crisis, they have no meaning, purpose in their lives. They're feeling very even suicidal. Um, and we need to instill hope. And that's, in my view, the best way to do it is to help them find other people who've been there and gotten out of it, and other peers.
And then Ebony.
Yes, hi, Dr. Kelly. Thank you so much for the presentation. I really enjoyed it. So I think my comment today is a little bit more personal than professional. So my brother, actually, we went through recovery with my younger brother, and I just wanted to say I really do hope that the recovery model, especially when it comes to family, starts to change and the information that they're told, because the information that you presented today is definitely something that we were not educated on when we were going through the recovery process with my brother. So, for instance, for his support system, we never knew about timelines, right? About recovery cycles and what that looked like. Um, and we were often told, to kind of leave him alone and that he had to make the decisions himself, right? And that there was nothing that, we could do, to support him in such of a way, like, that he would have to stay, at the recovery center. We couldn't, put him in anything like a lockdown unit. And that, I think it's unfortunate, because I think what Beth was saying about people feeling like the world is not made for them, I think that's part of it, is that we are essentially educated to leave the person alone, as though they need to make the decision to recover and heal by themselves for it to actually work. And so then the family or support systems tend to pull away and say, well, you know what, you need to hit this term that they would use, rock bottom, right? And then, you'll come around, and start recovering by yourself. But what we did notice is that the more we pulled away, the more he fell into the slump, and the more he would, go out there, and the addiction just got worse. And I feel like, a lot of us had to humble ourselves and say, you know what, he's not this diseased person that doesn't deserve love. And we need to say we're going to be there for him in certain ways. And so I think the more we did that, I'm so thankful that my brother was able to recover, and he's been now 5 years clean. He has his own apartment, he's working, we are so proud of him. But it really took, us as well. I mean, obviously he had to do the work. But I think for his support system, we had to re-educate ourselves, because the way the system is set up right now for family support or that peer support, they really teach those individuals to leave the person alone. And so I really think that we need to, with the grant that we have now, really changing that model and that information is so important. So thank you again.
Yeah. Well, thank you for that comment. And it's so inspiring to hear about your brother and your journey. Thank you for sharing it with us. It's the sort of thing that we need to hear more of and more about. Thank you for bringing it to us. And there's a good example right there of the need for, thoughtful, compassionate approaches. I think the old school approach was that, is that to withdraw, practice tough love, detachment with love, as opposed to engagement and support. Again, quote unquote, enabling the drug use, but enabling recovery, doing whatever we can to support and enable recovery activities and recovery-oriented behaviors with love and compassion, as opposed to, the potential, the perceived or purported therapeutic value of ostracization and alienation as a way of kind of helping them realize sooner. That can, in some cases, has worked, but in the majority of cases, does not work. And so what we have found with studies, for example, on the craft intervention, I'm not sure if you're familiar with that, but the community reinforcement and family training approach, the work of Bob Myers from the University of New Mexico, there's been now several studies showing how thoughtful, purposeful, compassionate engagement with love, strategically done, can dramatically increase the chances, something like 70% to 30% in the studies that he did, in terms of improving the chances that that person, that loved one who you care about, will get into treatment. And again, using much more of a strategic, compassionate, engaged approach as opposed to disengaged. So now we have good models. Now, it does take a long time for these things to get disseminated and for that knowledge to, to get out there into the world, as we all know. It can take a long time for that to happen. And I'm sorry that, maybe your brother has suffered prolonged addiction because of it. I'm just happy that he's got 5 years. That's wonderful. But we need to do to get this stuff out, get this new information out, the new innovations in clinical care, so that we can educate more families about these kinds of models and what to do, because families are desperate oftentimes, as we all know. They're desperate to know what to do. They don't know what to do. They're often sidelined in our clinical models, kept out of the picture. When they often play such a pivotal role in getting the person into treatment, and also in the post-stabilization phase, the family members can play an absolutely critical role, and we need to do a better job, much better job, of looking at models of care that incorporate families and family members and loved ones to support that person, because they don't know what to do oftentimes, and there's a lot of fragility and walking on eggshells in those early months and sometimes even years, in knowing what to do. But thank you for bringing that. Thanks for bringing that up.
Any other questions? I think one key takeaway I'm going to take it and kind of educate the community on with is about the, after the first instance of remission, and then how the quality or happiness of life kind of drops at that, like, I think we said 4-month part, because like the dust is clearing, I think the metaphor was. I think that reminded me a lot of like the grief cycle, kind of like when someone in your family dies, like, and it's like you're inundated with people at your door for like 2 weeks with like the food and everything, and then you're finally left alone and you're like, oh, now I have to work through this. I think that was like kind of the correlation I made with that one, so I'm definitely going to use that.
Yeah, I like that.
I think it's also similar to when people leave like domestic violence situations, and it's like, it might, that initial phase, and you have some support, but once some of that support is phased and you kind of realize like how much healing you have to do and things that you have to kind of like work through, it's like that slump before things actually end up really feeling better.
Yeah, that's really
feel confusing because you've left the situation. You should be feeling better, but you're not. Like, it's a confusing time, and I think it's very similar to that.
Yeah, it's almost like you've got time to contemplate, you've got kind of to think and reflect, and that reflection can be daunting, it can be kind of daunting, thinking, now what have I got to do now? Now that the dust is, the smoke has cleared out of the building, or the dust is settled, or whatever the metaphor you want to use. But yeah, it's something that we don't often attend to, and certainly sometimes we think, this person's got 6 months under the belt now, they're doing great, but that's the point at which really that dawning of reality can occur, and they can start to lose hope when they start to realize, what have they got to clear up and what have they got to make up. And that's a very daunting prospect, and it's something we need to be aware of in that second half of the first year, I think, to get them through that first year, because after that first year, it starts to go up again.
All right, any other questions, comments? Oh, Central Connecticut, I don't know who that is. Oh, Anne.
I have a question about supports at recovery support centers related directly to that time frame that you were referring to, that everybody's been referring to, which was really that chart was pretty amazing to see. And logically, it makes sense, especially when you do the fire analysis and like start looking around and assessing, oh my God, what has happened? And I'm just curious about the supports, like if people have gotten themselves into financial trouble and like the work and like all of those very detailed things that could help, and how much recovery support centers are able to, like I haven't heard much about helping people clear up financially what might have happened, and how do you go about doing that, and any legal issues, like all that stuff costs money and time. And so I'm just curious if you know anything about what can be available, and I'm not sure what's available in our area in those realms.
Yeah. Yeah, thanks for that. Yeah, I think the best thing I've come across is these peer recovery support centers, the CCAR Recovery Community Center type models you have in Connecticut, which I think were one of the you guys were one of the leaders in the country in providing this. And like I said, that kind of inspired me 20 years ago to do research in that particular area. But when you look at all of the, now they do vary a lot in terms of what they provide, there is no kind of standardized model yet of kind of a best practice model of these things. They're largely idiosyncratic, and they're devised and run according to who's running them. There are some, like in Massachusetts, we have about 45 now. And there are certain expectations, but largely they're run according to who's running them as to what the local communities need. But they often do provide this kind of legal advice and legal services linkage, as well as financial advice and financial services linkage to help people with debt and other challenges that they have. That's the best place I've found where they can get access to all of those kinds of things, including employment access, and they teach you how to write CVs and cover letters and apply for jobs, and have access to employers who will take people from their histories, etc., and get them income and get them back on their feet. Those are the best resources I've found for what you're talking about. Yeah.
Any other questions? Okay. So I just wanted to thank you, Dr. Kelly, for providing this great presentation and all the information. It was really amazing. And I want to thank everyone else for attending. As I said at the beginning, we'll be sending out the recording and all the resources that Dr. Kelly has mentioned via email. So
thanks, Holly, and thanks everybody. I really appreciate it. Thanks for the great questions too. And reach out if I can provide any papers or slides. Please reach out to me.
all right, perfect. Thank you so much. I
Thanks.
hope everyone has a good day.
How can we increase the chances that people will get into remission and stay in remission, stably in remission? And I'll talk a little bit about in that regard the